the 28th meeting in 2019 of the Health and Sport Committee, and delighted to be meeting in Perth this morning and to have enjoyed fantastic hospitality here in the city both this morning and yesterday evening. So thanks to all those who've been involved in providing that hospitality. We've received apologies today from Sandra White, Alec Cole-Hamilton, George Adam and David Torrance, but I'm delighted that our other members are here with us today. Can I ask, please, everyone in the room to make sure that mobile phones are off or on silent, and while it is acceptable to use mobile devices for social media within the room, please do not take photographs or record proceedings. As you will observe, proceedings are being filmed and recorded by the Parliament ourselves. So if you would follow that, we're very grateful. The main item on our agenda this morning is to take evidence as part of the committee's ongoing programme of scrutiny of health boards. We have had the opportunity to hear from a number of health boards across Scotland, and we are here today in order to be in Tayside to take evidence from NHS Tayside. And so I'm delighted to welcome to the committee representatives of the board, Grant Archibald, the Chief Executive, Lorna Burr-Stewart, the Vice Chair, Lorna Wigan, the Chief Officer for Acute Services, Peter Stonebridge, Medical Director, Stuart Lyle, Interim Director of Finance, all from NHS Tayside, and Gordon Patterson, Chief Officer of Perth and Kinross IJB. Welcome to you all, and as is the usual proceeding at our committees, questions and answers are through the Chair, and I will call members in turn to pursue lines of inquiry. Can I start in welcoming you to ask Grant Archibald, as the new Chief Executive, to give us an indication of your vision for NHS Tayside under your leadership.
Well, thank you very much indeed, Chair, for allowing me to do that. I commenced in Tayside 11 months ago. A dangerous thing to say in Perth. I'm a Dundonian and very proud to be back in Tayside. Tayside has for many years enjoyed a reputation as an excellent health board. We've had some challenges recently, and what we're keen to do today is demonstrate the progress we are making. If I might, there are three pillars upon which myself, the Chair and the board are seeking to build the future of healthcare services in Tayside. And those are clinical governance, staff governance and financial governance. And the reason those three emblems are important for us, because at the heart of that triangle is the patient. Therefore, what we seek to do, Chair, is establish that our clinical services are excellent, are safe and appropriate to our population, and provided in the right environments, which might not always be hospitals or GP surgeries, but out into communities. In terms of our staff governance, we believe Tayside is an excellent place to work. It has many attractions and many major achievements to its reputation, and therefore we want to ensure that when we say that staff are our most valuable resource, we mean it. We have 14,000 staff who work incredibly hard for us. Our job is to try and lead and guide them to get even more for our patients and in better ways and redesign, and that is a key component of our going forward. But we always want staff to feel valued, and it's important that we embrace both partnership working with our trade union colleagues, but also reach out and to provide services that mean that Tayside is a very attractive place to work based on its reputation and its commitment to its employees. And finally, and also importantly to us, is our financial governance. It is absolutely essential that we spend wisely the money from the public purse. We know the challenges that all organisations face in so doing, but a pound in the health service is the same as the pound in everyone's pocket. It can be spent only once, and one should only be spending what one has. And one of the major challenges I accepted in coming back to Tayside was that we would balance the budget by the end of a 3-year period. And we will report today on our progress in that regard, and it is good progress, but there remains a continued challenge. But we are up for that challenge, and importantly, in a model that we have developed in Tayside of clinically led and management enabled services, we are working with our clinical colleagues to find the best design for services, to make those as efficient as possible, and therefore deliver on the expectation, the reasonable expectation of the government, that within the 3-year period we will report a balanced budget. Thank you.
Thank you very much. Can I start the follow-up, if you like, with the issues you've highlighted of clinical governance and staff governance, leadership essentially. I know that the model you've proposed for the board includes a number of new posts, a number of new leadership posts of some importance. Could you tell us where you are with recruiting to those leadership posts and how far you feel you're making progress in that aspect?
Certainly, thank you. There has been quite a reorganisation in Tayside in the last 2 years. The board membership and indeed some of the management membership is unrecognisable from that period. So we've had a big changeover. One of the reviews we've conducted since I came into post chair was to ensure that we had the right people in the right places and that we had roles that were relevant to the challenges we faced. And therefore I made certain decisions about posts that we should have to develop. We had at the time I arrived an interim medical director sitting on my right. We now have the successful medical director for the post, and I'm delighted to welcome Peter to that. We currently have an interim nurse director as a result of a retiral, but we have arrangements for that to be filled from the 6th of January, and I'm delighted to say we've recruited somebody who's already a nurse director in another part of the health service. In terms of other posts, Stuart to my left is acting as the interim director of finance. One of the recommendations of the auditors was that we should have a full-time director of finance. We had been sharing with Grampian, and therefore we have put that post in place, and we are interviewing for that on the 5th and 6th of this month, of December. In terms of other posts, there are two particularly I would draw to attention. One is a deputy chief executive post that had previously been amalgamated with the medical director's post, and I thought that was too challenging and too broad a responsibility, and I shall explain why. And the other after that is a director of facilities, and that is to look after our estate. We are the 4th biggest board in Scotland. We are the 3rd biggest property holder. We have properties such as Nine Wells, which is now 50 years old, but we also have properties such as Auchterarder. We have properties up in Pitlochry. So we have a very mixed estate, and I think it's essential in our redesign of services that we also redesign that estate. In terms of the Deputy Chief Executive post, that post is key, Chair, because the way that we are going to transform Tayside in the next 3 years is by transforming Tayside. We are going to take services beyond hospital walls so that only those that require to come to hospitals will so do. We are going to optimise and become an upper quintile, upper quartile performer in terms of the delivery of our services. We're going to work closely not only with the integrated joint boards, of which there are 3, but also with our councils and our colleagues beyond there to redesign services across the board. And I thought that that was a key role and required such a level of transformation that I needed a dedicated person to lead that team. I do have some experience of that. I recently turned from 30 years working in the Central Belt. I opened hospitals in Wishaw and Edinburgh Royal Infirmary, and I was the chief officer responsible for the redesign of services to be located into the Queen Elizabeth University Hospital in Glasgow, which was a massive undertaking. So we do have experience in this vein, and my colleagues around this table also so. But we do recognise that we need to bring some additional resource to the table, and that is what we are doing.
Very much. Brian Whittle.
Yeah, good morning to the panel. I think you'll be aware that we took evidence last evening from members of the public and also from clinicians, and it was their very strongly held view, if I could put it like that the makeup of the non-executive position doesn't reflect the experience that they think that is required to deliver the treatments that they're looking for, especially around mental health, and also they felt that the age demographic didn't again reflect what would be needed from a non-executive position. So I wonder if you would care to comment.
I'll comment, and the Chair may wish to also. We have recruited almost an entirely new board. We only have 2 board members who served in the previous board of early last year. And our effort in that regard has been to get people who are interested and committed to the health of and well-being of the citizens of Tayside, but also those that bring a range of skills. And our efforts so to do, we are currently seeking to recruit those with additional financial skills to serve on our audit and other committees, and we have pro tem had some assistance from another board to support us in that regard. But in terms of the demographic, there is, I think, quite a broad experience across the board. There are people who have worked in charities, people who have worked for universities, people who have worked in the community, people who indeed have been radiographers and other staff members inside the service in Tayside. The makeup of any board is also dependent on those that put themselves forward, and therefore we are reflective of that. I must confess this is the first time this matter has been raised with me, and therefore with the Chair's forbearance I'm content that we go away and reflect on that further. I do not appoint the board members, as you know, and therefore what we are keen to do is respond to those that come forward. What I can say, candidly, is I've worked with boards all across Scotland in 5 different health boards, and I personally find the makeup of our board with the elected officials that come from the council representation to those that are come through the other nominated routes do reflect quite a broad spectrum and bring a lot of skills to the table, and I find them both supportive and critical friends throughout the experience I've had thus far. But perhaps my chair might want to say something in that regard.
We will revert to you, I'm sure, with some further requests for information at the end, but feel free to add any reflections after we've completed our session. Lorna Burstewart.
Thank you very much. There's been a significant turnover, which the Chief Executive just referred to, in and our demographic goes from the age of about 34 right the way through. Obviously, they are public appointments, and those are people that come through the process. But we have recently created a new public health committee, and that is with a non-executive chair and vice chair who have significant experience around the mental health agenda. We have quite a diverse board, and we have a good skills mix now. And with the exception, of course, that we want to create the 2 additional posts, which we expect to appoint by the middle of January. That process is going on at the moment. I don't know what that demographic is in terms of age, but we'll note those points and we'll take them forward.
Okay. Can I ask finally on the leadership? It's been drawn to our attention again and been an issue, I think, is leadership. Clearly, the appointment of Peter Stonebridge is clearly very significant in terms of a permanent post of medical director, but within the clinical leadership in different areas, whether that be oncology or psychiatry and so on, are there also areas there where you have concern of a need to strengthen clinical leadership within the board?
Again, I'm hugely impressed by the clinical body that I know inside Tayside, and again I have experience from elsewhere. They are a young and very enthusiastic group of people who are very much committed to taking Tayside forward and are keen to earn the reputation that we think their hard efforts deserve. Associate medical directors across the an excellent AMD who has stepped up in terms of our primary care services. In terms of mental health, we had an incumbent in post who stepped down, and in recent months we have appointed a new AMD on a temporary basis who is called Mike Winters. The reason we appointed Mike is I've worked with him previously in Lothian, and he had an excellent record both in Lothian and Lanarkshire of helping to turn around mental health services that were seen to be in difficulty. So Mike, who has in fact retired, has come back to work with us on a temporary basis, totally committed to supporting taking forward the mental health agenda. And already his ideas, his commitment, his engineering of relationships with different people give me huge enthusiasm that we have identified the right person to do that. And we recently, as yesterday, had a meeting with an oversight group at the Scottish Government. Again, Mike was there with us and would have been here today had we had a bigger panel. And he has excellent skills. I am therefore very confident that we're on the right track now and that we have the expertise applied.
That a permanent appointment? Or
No,
it's still an interim appointment.
Sorry, that's an interim appointment.
Yeah.
The issue with that, Chair, is we were keen to get Mike and he will bring his skills and take us through a series of stages, but we will be looking for a permanent appointment in due course. And I should say that Peter has a vast experience both in terms of his vascular surgeon experience working with the university and indeed working in commercial enterprise. He's been hugely supportive to me over the period. He carries the support of the clinical body, and he has been an excellent appointment to the board.
Very much. Peter Stonebridge, I don't know if you want to add anything in relation to the clinical leadership team with whom you're working.
Fundamentally, a health service depends upon everybody working together and everybody being equally valued. And it's my observation that where together, then we can make big changes. And so what we've tried to do is to make that team work. So one of the things that warms the cockles of my heart is watching our operational leadership team, where we have a relatively unique circumstances where we have excited finance people working with excited clinicians, working with excited managers, to try and make things better. Because fundamentally, we're all here to help people. And therefore, if we can help as many people as we can by working together, that's exactly what we should be doing.
Okay, thank you very much. Financial governance and leadership was the other matter highlighted at the outset, and I'd ask Dave Stewart to ask questions on that.
Convener, and welcome to the panel. As the Convener said, I'd like to move to the section on financial sustainability and note the points that the Chief Officer made earlier about financial governance being a crucial part of your new strategy and the board's new strategy. The panel will be aware that the Auditor General recently expressed some concerns about the lack of detail in the Savings and Transformation Plan. Can you tell me in detail how you plan to resolve that?
Thank you very much. If I might say a few comments, and then I'll hand over to my colleague Stuart. In the current year, we are confident of the figures that we're delivering and that we have a trajectory to hit the target that was set for us by the government, and I think that's important. But already myself, Stuart and other colleagues are engaging about what year 2 and year 3 of our functional recovery plan looks like. And at its heart is transforming Tayside. And to explain just for a moment, transforming Tayside is about, we will be making incremental changes, we will be achieving productivity gains, but what we want to do is transform how services work. Tayside has for too many years been providing services at a cost that cannot be afforded, and therefore we need to radically review that. We currently have a total of 97 schemes proposed by clinicians about how services could be redesigned. And what we've created now with myself, Stuart, and other senior members of the team, including Peter, is effectively an assessment caucus, almost a dragon's den, where their ideas are being brought forward and we're testing them. And the criteria they're being tested against is, will they deliver savings in year 1 or in year 2? What benefits will they deliver for patients, and how will we see that? And how will we be encouraged that they will allow us to achieve the financial plan that we need to do? So if you look at our detailed proposals next year, we say we will achieve £7 million worth of savings through that redesign programme. And that is why we are in the stage now of working through the whole array of schemes to identify those that will deliver quickly, those that might take longer time. We have a whole criterion metrics against that. We're running this not as a business, but in a more business-like way. And therefore, there's also issues about invest to save. So colleagues will be aware of social prescribing, where the idea is, and I know members of the panel are interested in diabetes and not least the increase in type 2 diabetes. But if we could get people exercising, if perhaps we subsidise gyms, then type 2 diabetes is avoidable and indeed reversible. And that is far better than giving someone a pill. So we're engaging about that. But in order to do that, we are that by making certain investments to set up new services, we need to get a return out of that of greater value, and we're testing the whole environment regarding that. So those are the frameworks in which we're working, and then perhaps Stuart could give you some more of the detail if that's acceptable.
Thank you. Good morning. If I look back to last financial year and comment on this year in terms of savings, we over-delivered on our savings plan last financial year. At this moment in time, in the current financial year, we've identified 98% of our savings plan, the high degree of confidence that, again, we will over-deliver. I don't have concerns about our ability to deliver savings. I think the approach we're taking in terms of the clinical leadership model and the engagement we have around that is fundamental to delivery of savings through transforming Tayside and just We've had a few successes in relation to that, which I'd expect to continue on, and they are the recurring successes that will give us sustainability going forward. So if I reflect on GP prescribing, for example, as we sit now, our actual spend in GP prescribing is in excess of £2 million lower than the previous year. That's a whole system effort, and that is sustainable. Secondary care drugs, working with our clinician colleagues, they've set up good governance models around the medicines management groups within each of the clinical care groups, and they've managed to stabilise the spend in secondary care drugs. This year against last, it's the same. That's against the background of nationally costs are increasing between 7 and 10%. So there's good examples of how that leadership is paying dividends. If I think about our unscheduled care performance, so investment in the right areas in the community and the social care is taking costs out of the hospital system. And again, we saw that happened. Our winter plan last year was successful, and it's been held up by government as a good model that other boards could replicate. So in terms of sustainability, the savings we're making are those savings that will be sustainable going forward. So I'd expect next year, yes, we can implement elements of transforming Tayside, but we will see a continuation of the good work that's been in place over the last 18 months.
Okay, so you're convener. I mean, what I'm hearing and the committee hearing, I think, is all very positive. I suppose the big picture, the question perhaps the public are asking as well, is at the end of the 3-year period, will the board be able to break even without the use of brokerage?
At the end of the 3-year period, our commitment is to break even without brokerage. That was one of the reasons I applied for the job and took it. And I'm understanding that that is an absolute responsibility that I have to carry with my board. The issue that we have is that transforming Tayside is a metric for us taking this forward, but I am aware through PAPLs and other environments that government have heard previous representations from Tayside about budgets. Let us be clear, the levels of granularity that are going to be required to put us on a better footing are being put into place right now. As Stuart says, one of the things that we wanted to do, and I'm sure you would understand that, is secure year one. And that is what we've invested a lot of our time in the first part of this year and the first part of my tenure. But we are absolutely focused on the fact that we must have the levels of granularity that demonstrate our ability to assess and indeed review our steps towards achieving the targets for year 2 and the break even by year 3.
And that's good to hear. So you, convener, you will know following our previous inquiries that we've looked at the bulk of boards in Scotland, and there is some common denominators, particularly among boards which have a rural element like yours have. And there have been some questions asked whether some boards are financially sustainable at all. Can I particularly raise the issue of brokerage? And for those who are watching the gallery, brokerage really is financial help from government. Can I just confirm that I've got the facts right? My understanding is you've had brokerage for 7 years and that you've received 67.8 million in brokerage and you've repaid 4.3, and there's been no repayment since 2014. Is that correct?
Those figures are correct, and Stuart may want to comment further.
I had further questions, but
those figures are correct. Yes.
Right. Now, there is some debate, as you will know, and the committee has pursued this, of whether current brokerage is to be repaid at all. Could I just, for the record, so that the committee is clear on this, because there is genuine confusion, what is your understanding about brokerage you have received or have been promised? Is it to be repaid or not? Because obviously you've only repaid a very small percentage of 67.8 million currently. Are you expecting to repay the rest of that? Or is the assumption for financial sustainability the fact that you will not have to repay that brokerage? Is that part of the calculation for breaking even over a 3-year period?
The previous brokerage was written off, or rather underwritten. The challenge that we've got going forward is over the next 3 years, as you'll see from our figures, we do need brokerage until we get to the end of that period. And the clarification I've heard this asked in previous of your committees is yet to be established over what period that might need to be repaid. But the first achievement we need to deliver is break even in real terms, and then the issue of the brokerage that allowed us to put ourselves in order will then be discussed. in detail.
So just to be clear, so that I've understood this correctly, that the bulk of that sum, that brokerage that's outstanding, will not be repaid to the Scottish Government, because that's the basis of the brokerage that you've received.
That's true.
Right. And when at the end of a 3-year period, you would expect to break even without any further brokerage?
Yes.
Right.
So at the end of the 3-year period, we will be financially solvent. And the brokerage that has allowed us to get there over the period of that time will be a project that's still ongoing for discussion regarding what happens to ourselves and other boards that are in similar circumstances regarding if that is going to be repaid over a certain period of time or what the arrangements are. I'm sorry, I don't have those details.
Right, but I think I've got the general thrust of that. So finally, conveners, I'm conscious of time. Would you say then, after the various questions I've asked around brokerage and all the work you're doing to ensure that there's savings in the future, that Tayside is financially sustainable?
Yes, and I think there's a focus for me, if you don't mind. We get 950 million pounds to run health services in Tayside. It's almost £1 billion industry. And while we can focus on savings, and I understand that, the real challenge for myself and my team is how do we spend that money wisely? And how do we govern ourselves in the same way as other organisations do in the public sector, which is to ensure we are break-even. So I recognise entirely that of the track record of Tayside, there is a challenge to that. I understand that. But what I am trying to articulate is we, by putting in new mechanisms, new ways of working, governance arrangements, levels of granularity and challenging the system, are looking importantly with our colleagues in the redesign of services to make sure that we break even.
Camilo?
Thank you very much. Audit Scotland also commented on the overspend in relation to Perth and Kinross IJB, and I wonder if I could ask witnesses what the position is with an IJB overspend within Tayside. How is that addressed? How far is that the responsibility of the individual IJB, and how far is it something that NHS Tayside takes forward?
If I might start, convener,
Please.
and then Gordon will give a further amplification. The situation is we have 3 IJBs, for those that don't know, in Tayside. We have Dundee City, we have Angus, and we have Perth and Kinross. We have excellent relationships with the 3 chief executives of the councils, and indeed I meet with them on a monthly basis, and we actually meet now on a monthly basis not only as chief executives but also with the chief officers of the IJBs. And the reason we do that is we are a common concern. The patient in Pitlochry or Perth or Dundee, it doesn't really care where services start and stop in terms of who runs them. They just want to know that they're cared for. And our obligation is to make those services work on an interdigitated basis. That means that they are safe and they are appropriate. But we also need to look at how they are affordable, and that's a challenge that we confront in the same ways we do in terms of directly managed services. So we have our meetings regarding our arrangements with the 3 councils and the 3 IJBs, and we explore where we are financially with them. You're right, there is a pressure in the system at the moment, and that has been identified through the arrangements we have between ourselves and the Integrated Joint Board, and there is a pressure in Perth, and I'm sure Gordon will say a bit more about that. But the commitment that we have is we work together, ourselves, the council and the IJBs. We have a common concern here, we have a common commitment, and therefore how do we best help each other make the best use of resources and make sure that they do work on a seamless basis and do not collide or indeed duplicate themselves in an unhelpful way. But perhaps I could ask Gordon to give further comment.
Certainly. Gordon Patterson.
Thank you very much, and good morning, panel. It is the case that at the current position, projected overspends at Dundee and Perth and Kinross IJBs have projected overspends. I think it's important to frame this in the context of our assurance that we are committed to ensuring good financial stewardship, but we are facing significant challenges in terms of service demands. The overspends, I think, are a reflection of our commitment to spend the right money in the right place. We are consistently delivering good performance in achieving the national outcome indicators, and the demands that we are facing in relation to a significant growth in the number of older people, the prevalence of dementia, the complexity the longevity of people with learning disability, compounded by, in Perth and Kinross and Angus, the rurality of some parts of our areas and the levels of deprivation that are being addressed in Dundee City, mean that we're in a position where we are projecting an overspend in Perth and Kinross. The arrangements at the year end, should we have an overspend, will involve the council taking responsibility for any overspend on the social care side of the budget. The NHS will take responsibility in relation to overspends on health services. A different arrangement, a different risk-sharing agreement exists in Dundee and in Angus. So Dundee's overspend will be absorbed by the NHS in relation to 2/3 of the total overspend, regardless of its source, and the council approximately 1/3. There is an ambition in Perth and Kinross to move to a position where we have a consistent risk-share agreement to the other two partnerships. But the focus of our activity and our collective endeavour has been about how do we deliver financial balance and how do we achieve financial recovery. So both Dundee and Perth and Kinross have brought forward financial recovery plans that they have had approved by colleagues in the NHS on the board and in the IJB. And we are seeking to bring forward measures that will get us to a position where we are hoping to deliver financial balance. Now, that will prove challenging. It is about how we can transform some of what we do. Some of that will take perhaps be more about a medium-term ambition. But in the meantime, we're looking at activity, we're looking at service reviews, we're looking at how we can do things different, we're looking at how we can make best use of our available resources to try to get to a position where we're delivering balance.
One of the things the committee has found across the board is that the progress of integration is very variable from one area to another, and I think what you're telling us is that it's very variable, or variable at least even within Tayside between one area and another. Do you accept that there's an issue here where funding from the Health Board on the one hand and from the local authority on the other hand has not retains a separate identity, and there remain separate lines of accountability which don't sound at all integrated to my ears?
I wonder if I could give a Health Board perspective and then Gordon could give his. I've worked in the health service 35 years and for all that time we have talked about working in a more integrated way and about more care being delivered more locally to patients and reflective of patients' needs, and we have tried very hard. I think the last 3 years shows a level of commitment from the government and from the health service and other agencies to try to make that far more real and far more demonstrable. And therefore the creation of the integrated joint boards and the creation of the health and social care partnerships I see as a major step forward in that regard. I should say though, however, that we are in effect trailblazing there because nobody quite does it like that. And therefore, as we go forward, there is a learning process, there is a developing process about we integrate different parts of the networks that exist in Tayside and indeed in Scotland. Councils are different from health boards and they have different drivers and challenges at times. That being said, I think that we are now maturing into a process where there are far clearer engagements and there are far better understandings of routes for patients. And we're getting into those discussions about how does the patient journey, for want of a better phrase, start and end, and how do we all work collaboratively to ensure that is the case. You're entirely right, there's a variability in the risk-sharing agreements which were set up in Tayside some years ago. That's a technical matter and we have ongoing discussions with our colleagues in Perth and Kinross. But the real benefit I see from this is that in Tayside we are of a size where I can sit down with 3 chief executives of the councils and have very joined up discussions about our aspirations and indeed with our IJBs. And if I might take an example to give you some further insight, Convener, and it's actually from an issue that might be seen by some as a negative, which was the Dundee Drugs Commission. And it reported that there had been a series of challenges regarding our provision of services in the city of Dundee, and also people will be aware of the drug problem that is identified there and also the number of deaths amongst drug users. Off the back of that and from the Dundee Drugs Commission, we have created a whole body that is looking at the whole experience of those in need and their families, involving the third sector, the police, fire and ambulance, ourselves and the council. And I can see real developments arising from that already. And those are the sort of positive engagements we need to have. Those are the sort of examples we need to develop, because in developing those, we find better ways to make ourselves work together, and we find real examples that we can share with the public and with others to demonstrate that this is a work in progress, but also something that's going to achieve change. So there are aspects of integration that are about the technical arrangements and risk sharing. I think the bigger challenge and the better challenge is about how do we make a service that involves multiple agencies appear seamless to the users, and how do we make that efficient? But Gordon, you may want to say something more.
Gordon Patterson.
Thank you. So perhaps not much more. I think where we're at in relation to our integration journey is perhaps a reflection of where we've come side. We perhaps in Perth and Kinross have not achieved the same degree of integration and that level of maturity that perhaps is evident elsewhere in relation to that journey. That, though, is, I suppose, the challenge for me as a relatively new chief officer with a new chief executive in the council and a new chief executive in the NHS Tayside. The variability in no way reflects a lack of ambition for us to drive forward the pace of integration, to achieve synergies, to join up services and to ensure that the patient, citizen, service users experience, as Grant says, is not able to detect whether or not it is a council service, a health service, an IJB service. So we have a shared ambition. We have the conditions to drive forward integration much more effectively. We learn from each other, the three partnerships in Tayside, but equally we are open to look at, borrow, steal the ideas that are emerging across Scotland through the work of the IJBs and health and social care partnerships with whom we connect regularly.
Ask either or both in making that kind of change and seeking to progress integration and make it as user friendly as possible. How are staff side partners involved in that process, and how are the public involved in that process? Is it simply driven from above or from the centre, or are there ways in which you engage with the workforce and with the public?
If I may start, convener, on that regard. I have said we've got 14,000 staff inside health who are incredibly hard working. Indeed, they're all working very hard today. Part of our challenge is to marshal that effort into directed action so that we get the best achievement. And our ambition is that everybody goes home at night feeling they got out of their job what they put into it. Key to that relationship is our partnership working, and we have well-developed partnership relations inside NHS Tayside. You will be aware we have an employee director who is a member of the trade union who sits on the board. That employee director sits in all my senior meetings and helps to discuss the agenda, and partnership working exists at all levels inside NHS Tayside. And therefore, in our commitment to go forward, I am quite clear. It is far better to walk alongside or lead 14,000 people rather than try to push them. And in terms of our relationship with the councils, again, we are engaging on a partnership basis. There are challenges. We have challenges in some of our services at the moment, but we are working our way through, and we continue to engage with our staff partners in understanding where challenges are. We have an area partnership forum, which involves all the staff side representatives across Tayside, and the three IJB leads sit on that as well.
And can I ask Gordon Patterson, in similar vein, how the IJB in this case engages with staff, given that staff are coming from two different employment backgrounds, and also with the public in delivering those services?
Thank you. So similarly, I suppose each of the health and social care partnership has a local partnership forum, which involves staff side, but equally involves representatives from the trade unions who are representing the council staff. So we have those joint forum where we discuss matters in relation to change, new service models, any issues that have arisen, health and safety, staff survey, matters, are all standing items and are regularly discussed. We also then feed into the area partnership forum, and in recent weeks we have across Tayside established a partnership forum to look specifically at learning disability and mental health services, and we've had a couple of meetings of that forum. In terms of consultation and engagement, I think it's probably also important to reflect the fact that when the health and social care partnerships are bringing forward proposals around service redesign, or in the process of pulling together strategic plans around care groups, we work very closely with the third sector. We're involved in engaging with communities, we connect with community councils, and we seek to walk that path with people who will be affected by any of the changes that we might make.
We'll come back to a more substantial discussion on mental health, I'm sure, later in the morning. But can I ask a simple technical question at this stage, which is, where does responsibility lie for mental health in patients? Does it lie with NHS Tayside? Does it lie with the hosting IJP?
We take ownership, myself and colleagues in the board take ownership for the care of patients. That's one of the responsibilities we have. Ultimately, the responsibility as the accountable officer for the delivery of healthcare to anybody in Tayside lies with myself. The arrangement for hosting of services was to try to create environments where there could be co-ownership of services and make them work more collaboratively. And therefore we have an arrangement where in Tayside, it's a slightly different model from where I've worked elsewhere, there is a delegation of responsibility for mental health services. In terms of community services, each of the individual IJBs deal with that, so Dundee, Angus and Perth and Kinross. In terms of inpatient services, they are delegated to the Perth and Kinross partnership, and indeed they commission and lead services in that regard. That being said, we clearly need to work collaboratively, and that's part of the process of my bringing in Mike Winter and others, because we recognise, as we will get into no doubt in the agenda, as you said, Convener, there are challenges around mental health in Tayside that have been there for some time, and we are keen to work together to solve those. So ultimately I'm responsible for the services with Peter, but in terms of the hosting arrangements, they reside with Gordon's IJB.
Thank you very much. Emma Hart.
Thank you, Convener. Good morning, everybody. I'm interested in a few questions about the operating model. In the 2018-19 audit report for the board, it states that the board has an operating model that is seen maybe to be more expensive than other boards. In NHS Tayside than other boards, and also the average inpatient costs are more expensive than other boards, and the total prescribing costs weighed per patient in NHS Tayside have been higher than the average due to a combination of more items per patient and more expensive items. And for me, as a nurse who for 30 years who understands the critical nature of appropriate staffing, whether it's acute care or in the community or primary care, I'm interested to know, are the staffing increases, is it clinicians, is it other areas, is there a plan to potentially address that, as well as prescribing? You've talked a little bit about exercise, social prescribing, which would replace maybe prescribing for diabetes and type 2. So are there ways that you're exploring these opportunities for cost reduction, whether it's in staffing, whether it's inpatient costs, as well as medicines?
I'll take that first, and then my colleagues Peter and Lorna may want to comment on acute services, and Stuart may want to comment on the actual finances. I'm a great believer in comparisons, and what I've done since I came to Tayside is look at ourselves and try to understand us in comparison to our cost per capita compared to the other boards in Scotland. We are not so different that we should have differentiation. And therefore, what we have been doing is establishing who are the upper quartile, upper quintile performers amongst boards elsewhere, and where are we relative to those. So in terms of length of stay, in terms of start and finish times of theatres, number of cases on theatre lists, new to return ratios in outpatients, we have demonstrated that our number of times we bring people back to certain outpatient clinics is very different from the rest of Scotland, or at least the best in Scotland. And therefore, on that granular basis, which maybe comes back to Mr. Stewart's point, we are getting into all of those elements to understand what is driving cost, why are we different, and is there a good reason or is there not? And where there is not, we expect ourselves to then correct our delivery. I'm quite shameless, having worked in 5 boards. I think we should look over each other's shoulders at each other's jotters. So if people are performing better in any other part of Scotland, we go and see them. There is a lot of interest in looking at international models. I've encouraged my colleagues that we look at Fife and not at Finland, because we have far more in common with them, and if they're doing better than us, it's a drive across the bridge to find out why. So we're taking it down to that granular level. When we've talked about redesign, we are talking about why should our models be different, what are the best models, and what are the most efficient models. And that is the process we're undergoing at the moment. In terms of our staffing, we do have a more expensive staffing model, but when one thinks of the standardised nursing staffing model now, then that dictates what we will be using in wards and departments, which will be standard across Scotland. In terms of our medical staffing model, at the moment we have some issues, as do other boards, in utilising locum staff, not least in our mental health services, where they're costing a very significant amount, and anything that we can redesign to change that. So if I might, although I know you want to go into mental health later, we have 14 consultant vacancies in mental health at the moment. Recruiting psychiatrists is a challenge across Scotland. I'm not confident that we're going to be able to get these people. In the absence of those, we are having to use locums. I find locums a poor use of money because they are expensive and they are not people that are embedded with the service. Therefore, working with Mike Winter, who I've trailed before, he has identified that we should transfer some of the resources from 10 of those posts to create 10 nurse consultant posts and recruit into those and redesign the model of care. So it's those sort of real examples that we are developing, which is not only about the numbers of the workforce, but changing how the workforce works. And can I just applaud our workforce at this stage, if you don't mind, Chair? Because we have one of the lowest sickness absence rates in Scotland. We are below the national average. We have a vacancy of only 5%. So it's in key areas, and recruiting to those key areas is difficult. But we have a lot of people working enormously hard. And when we hear things like we have an expensive model, I know that's a challenge to them. But our commitment is we're going to work alongside them to redesign more affordable models and different models. And not to be the same as others, but actually to be in the vanguard. So if we look at some of the decisions the board made just 3 or 4 months after I came in, we have a differentiated model now of urology, which allows a one-stop shop service. Sorry, that's a bit vernacular, but it means when you turn up at your outpatient, you get everything done in one day rather than having to come back to several appointments. That is up and running in Perth as we speak, at Perth Royal Infirmary just down the road. We've looked at a separated model around orthopaedics. You asked about our consultation with the public. We have gone out to the public, and I believe we've had 375 comments on our plans there. We are working on a thrombectomy model, which sees patients passing by Perth to actually get to an excellent established service in 9 Wells and allowing them to return home. So that's a redesigned model. And then we're looking at absolutely new models such as thrombolectomy, which we have just secured £650,000 from the Scottish Government to allow us to progress a model there. So we are looking at these models, we are looking at developing different services, we are doing it with our staff, but we do also understand that we need to become affordable, and that's a commitment that we explore every time we engage with the partnership services, so that we know that working in partnership is clear. And when we work our clinician colleagues, Peter could attest to, the challenge is there again. We need to be affordable, and we are absolutely committed so to do it. I don't know if Peter or Lorna want to say something specifically about acute services.
With respect to me, I was... Oh, Lorna's points. With respect to me, Grant was ticking off the issues that I was going to bring up one by one, so I was running out of them. So fundamentally, we have done an NRAC assessment of staffing per population for the medical clinical services, and essentially just about everybody's within our statutory NRAC, and where they fall out with that tends to be super regional services. And the classic would be dermatology, and that my own specialty of vascular surgery covers into Fife, and that's quite a common thing for Tayside to supply services for others, and therefore we do serve a population greater than our book population, and hence the numbers are there. Clearly, in terms of an expensive model, we're running off an old hospital, and we're readapting the way that we're using our estate to be able to be much more modern in our approach, and hence I was going to bring up urology, I was going to bring up orthopedics being centralised, and elective orthopedics being centralised, because the way, the dynamics of delivery of clinical care is very different between elective services and emergency services, and to get the necessary bang for your bucks, then you probably have to separate them significantly, and that's where we're exploring with everybody involved in the patient population to see what would be an appropriate model going forward. It's certainly, in many cases, not the model that we have been running over a number of decades, and we're moving very rapidly to a more advanced approach.
And take Lorna Wigan.
Yeah, just with respect to, obviously, the workforce model, we are aware that there are areas within our service where we can be more productive and more efficient, so we have a specific programme of work which is looking at both our use of day case. So we've had some quite good successes, specifically creating new day case units in order that patients can come in on day of surgery and be discharged on day of surgery, and that's let us look at a whole new model, which obviously then lets us look at a different model for the workforce that support that as well. We have our clinical leads now who are very engaged in secondary care, and we had a challenge from our interim director of finance to flatline spend in acute services this year, and actually through the efforts of all the teams we've actually managed to achieve that. So there are some very, very good things happening with respect to how we use our resources to ensure that we can demonstrate that our workforce is appropriate and the way we provide services is as good as within upper quartile, which is our challenge from our Chief Exec.
Emma Harper.
Thanks for that. I guess the issue with the prescribing, is it inpatient prescribing that is higher, or is it primary care? But also, I'm interested in length of stay of, say, the orthopaedic patients, the fractured hips. Is the length of stay higher than in other boards? Is that one of the issues that needs to be addressed?
So that question first, and then I know that Stuart's keen to explain further around pharmacy costs. So in terms of length of stay, we do have some outliers in terms of our surgical service. The challenge around using day case rather than admitting patients. And as we go forward, we are taking a decimation approach of mine, which is top 10, top 10. So on a weekly basis, at my level, I'm reported to the top 10 clinics that have had the poorest new return ratio, the top 10 theatres that have had the poorest throughput, top 10 areas where the length of stay has been highest. And by that approach and the granularity, what we're trying to do is go to the exact areas where that's occurring with Lorna and our colleagues and say, this is the evidence we're seeing, what are the models of care here and why are others doing it differently? And importantly, Scotland is not that big a place. Glasgow's 90 miles away, Edinburgh's 60 miles away. Let's go and see other models. I am unapologetic about learning from others. We, in front of you, will not always have the best ideas, but we can learn from others and we can put those ideas into place with the support of our colleagues. And that will bring us back. My ambition, in order to get us back into our spend per budget, is to make sure that all our performance indicators are in the upper quartile, upper quintile, but importantly also that we have radically new models that will allow us to go forward from there in an integrated way with our colleagues in the IGBs, the HSCPs and with the councils. Stuart, you maybe want to say about pharmacy?
Thank you. Thank you. So in terms of prescribing, the NHS Tayside's historically had a wide variation in terms of its GP prescribing costs. So we're sitting about, if we go back 3 years, we're sitting about 9% above the national average cost, which in pounds terms is a lot of money. It's high seven-figure sum. What we've seen over the past couple of years is that the level of variation is now about a third of that. So there's been significant progress over the period of two to 3 years.
That's now about 1% above average. Is that
about 3%? It's about a third of the 9% that was there previously, so it's about 3%. That percentage variation is coming down quickly. In terms of our you mentioned price growth, volume growth. In terms of our price and volume growth, it's significantly below the national average growth this year. So I expect that variation by the end of this financial year to be even lower still. So there's significant work, and again, this kind of plays out in terms of that leadership we've had from clinicians, including GPs. It's been a whole system approach to driving that out. It's been a success story in terms of moving towards a more sustainable financial position. In terms of being an expensive operating model as a whole, I would just give the committee assurance that in terms of, that's reflected, if you like, in terms of the financial gap that we carry forward from year to year, what we call our underlying recurring deficit. I would just give the committee assurance that that underlying recurring deficit reduced by 20% coming into this financial year from last year. But it demonstrates the progress that we made last financial year, and I think the Audit Scotland did reflect that in the audit report at the end of the year. We're seeing that continue to reduce over the course of this year, so we'll have a smaller gap going into next financial year. And as we've discussed in terms of getting towards that 3-year plan, by the time we reach break-even, we'll be in a much more financially sustainable position.
Thank you.
The thrombectomy service that's been established do you have a time scale for that, when it will be implemented? And then I guess you'll be measuring all of the other areas to look at savings. So when do you project that you'll have numbers that will show positive changes, I suppose?
Rhonda, you want to talk to
Rhonda?
Yeah, so for thrombectomy, at the moment we just have our clinicians who are being trained. Obviously it's a new procedure, so therefore they are undergoing the training at the moment, and the plan would be that it will be a phased implementation, and the first patients obviously to be treated will depend on our clinicians being competent to undertake that procedure, and that looks like that will be early in the new year. And then the model obviously will be evaluated just to ensure that it's delivering what it expected to, and at that point it then will be rolled out across the north.
Okay, thank you very much. Brian Whittle.
Thank you, Convener. Just a quick supplementary to Emma Harper's question there around length of stay. We heard a little bit of evidence yesterday that the services, ones, for example, towards the end of the treatment, that when they should be going home or could be going home into the community, there's a lack of care in the community that allows that discharge to happen. Therefore, the treatments that the patients are receiving remain in hospital when it could be in the community. Is that something that you recognise?
There's an unfortunate term that's used around that, which is called delayed discharges, and I think that disempowers the patients. We have patients who are in hospital who should not be, and our absolute commitment going forward is that should not be the case. I think there's a couple of things to reflect. That there is something about the improvement journey we're on. So we actually reduced the number of days that we call lost to those patients by 15% in the last year, and the Scottish average, I believe, was about 1%. So we made a very significant improvement. We have further to go, and that's about making sure our services in the community are established in the way that it makes that access easy, and that we look at models that are supported. So it might not always be about care home placements, it might be supported at home. So we have made improvements. We are on an improvement trajectory. We have a way to go yet. But the real thing that we need to focus upon is all parts of the service are working very, very hard, but we need to find ways that they link together even better than they do at the moment, and that allows patients on their journey, as it's called, to find that it is seamless from start to finish, and they find themselves in the right place on each part of that journey as well. So we have seen improvements in our delayed discharges. We need to improve that further. That's a debate that goes on with our IJBs, and that's a challenge that we set ourselves year on year, and we do have trajectories for that. But as I say, we are better than Scotland in many regards, and that is some benchmark, but not the only benchmark.
I don't know if Gordon Patterson wants to add anything.
Yes, thank you. So just to reiterate the commitment that we have within the IJBs to invest in new care pathways and to do whatever we need to do in relation to managing and stimulating the market to create the conditions for us to have the care at home services, the care home places, to enable people to be discharged from hospital as soon as they're safe to be discharged. I think from the Perth and Kinross perspective, for example, in 2015-16, 19,900 bed days were lost as a result of delays. That figure came down to 12,200 last year. So we have made significant progress, and I think equally colleagues in Dundee and Angus are doing likewise. And as Grant says, we are by no means complacent about the significant challenge that brings, and the recognition that when people need to leave hospital, they need to leave hospital because that bed can be made available for someone else, and it isn't the right place for people to continue their recovery and rehabilitation.
There's a flip side to that. Again, we'd heard some evidence that, especially in orthopaedics, and once people have been discharged, the through care in terms of maybe rehabilitation and physiotherapy, sometimes is not being received for up to 6 months after discharge. You mentioned there around the fact that the delayed in discharge has reduced significantly from 19,000 to 12,000. Is that my question to you? Is that being forced? So that the treatment required post-operation is not available to the patient for up to 6 months. Is that been driven? Is that forced?
No, I mean, I'll maybe ask Lorna Wiggins if she's got any details in relation to the waiting times for some of those services, but certainly from the perspective of the IGBs and the Health and Social Care Partnership, we are in and around the hospital environment and participating in multidisciplinary discussions about when someone is medically and clinically fit for discharge. That then initiates interventions, be that care, a home care service, a nurse service, and critically also assessment by occupational therapists, physiotherapists, and the provision of services at the point of discharge. So I'm not aware of significant delays in relation to rehabilitative services. We can look into that and provide further information, but I don't know if Lorna has any more detail.
I'm certainly not aware of that being an issue. It's certainly never been raised with us, post-discharge for our orthopaedic patients getting the rehab. So that would be something I would want to take away and just have a look at, just to see what other information we can provide for the committee.
Very much. Before I bring in Miles Briggs, just you mentioned when you arrived and looked at the operating model, you were struck by the fact that in Tayside, inpatient mental health is delegated for the whole region to one IGB. That's at least unusual, if not unique. Is that something that you're looking at in terms of the redesign of structures that you talked about earlier?
Yeah, it certainly was different from models I'd seen elsewhere. That being said, the form follows function. If we can demonstrate that it can work in that environment, then that is what we should do. If we think that that structure in any way would impede the efforts that Gordon, myself and others are seeking to make in improving mental health services, then clearly we would look at that again. But at the moment, our concentration is how do we make the model work? And that's about the model of medical care and support care in the community. And then beyond that, if we find that any of our structures are an impediment to progress, we then would be honest enough to have that debate between ourselves and the IGB and indeed the government.
Thank you very much. Miles Briggs.
Convener, and good morning to the panel. I wanted to ask some questions around oncology in Tayside, because earlier this year it came to light that oncologists had been giving breast cancer patients a lower dosage of the chemotherapy drug, which is intended to prevent the spread and return of breast cancer. Now, the clinicians stated and contended that this was to reduce toxicity and the side effects associated with these drugs. So I wanted to ask the panel this morning, what happens when an individual specialist in NHS Tayside disagrees with national guidelines, and who's held accountable around that?
I'll let Peter talk. Sorry, Chair. I'll let Peter talk in a moment regarding some specifics around that. But if I could just frame where we were with breast oncology services. Services were being provided in Tayside. There is a well-recognised problem with any application of anti-cancer drugs in that they have a toxicity. They do harm as well as good. And sometimes that harm can be very severe. It can be neuropathy, where people lose the feeling in their hands and feet. People can lose their eyelashes. We all know that they lose their hair, and they can lose some cognitive abilities. So the assessment of any consultant would be to do more harm than good would be the absolute obverse of where they want to be. So they have to make that judgment. You're entirely right. There were discussions that then led to a series of reports in Tayside, and we have put in a revised model that involves the consultation and the explaining of to patients in the consultation process very clearly about the standardised models being delivered in terms of the amount of dose that one would get, in this case 100 milligrams of docetaxel, as compared to what you might get with 80. And that is an ongoing debate that has to be undertaken between the consultant and their patient. But again, you're right, we need to frame that in the context of what is national guidance, we need to frame that in the context of what is best practice, and we need to frame that in the context of evidence. What is the evidence for what we are doing? And if there is a variation, it cannot be unwarranted variation. I have taken on the responsibility to be the chair of the North Cancer Alliance, which basically, chair, is responsible for making sure that we work in a coherent way across all the northern boards, from Tayside up to Shetland, etc. And as part of that narrative, we're developing standardised dosage ratios, CMGs, and advisory groups that are being signed up to by the clinicians to understand exactly that we are doing the same thing. But clearly within that, there can be, and Peter might talk more eloquently to this than I, clearly within those guidelines, there is always the assessment of the patient in front of you. I might receive something different from yourself, Mr. Briggs, and therefore that is a judgment. And in that judgment of the clinician, they need to evidence why they arrived at that. And importantly for me, most importantly for me, they need to evidence that they have had that discussion with the patient on an informed basis, such that they can arrive in an understanding. And part of all of this is about our commitment that patients need to be involved in their care. They need to understand the risks of what we do and the benefits of what we do. And that needs to be an adult conversation. It needs to be an informed and partnership conversation. But perhaps Peter might want to say something more about variation amongst consultants per se.
So fundamentally, there is a nice guideline around breast cancer neoadjuvant chemotherapy, but it is regime-based, not dose-based. And so the difference was that the usual regimes, rather than a standard regime, were being taken elsewhere, and following internal audit, they decided that the toxicity was unacceptably high. But there is no national guideline around 100 milligrams of docetaxel. There is a national guideline around the use of docetaxel. If you are at odds with NICE, if you look at the medical legal background to this, then NICE would say, okay, that they're a guideline, not a standard, but equally clearly the legal position would appear to be that if you vary from NICE guidelines, then you have to consent and document the reasons why you would do that. Oncologists consent on regime, not dosage, and therefore the shift from what just about everybody else does to what you do, I think, required consent. The oncologists in Tayside now have fully signed up to the CMG for the north of Scotland, and our patients are being fully consented around what they receive. My parallel is, as a vascular surgeon, there are a number of approaches I can take to certain conditions. Some of them are more extreme than others. It depends upon where the patient's priorities lie. And every individual patient is individual about it. It's their life, in my case, and their limb, in which case they assess the risks and benefits of a treatment in collaboration with the clinician. Sometimes they ask advice. I tend to say, well, it's your life and your limb. I'm not going to tell you what to do. And I think I'd like to think we're ahead of the curve in terms of consenting around oncology in light of these events.
Well, please.
We often discuss realistic medicine as a committee in terms of direction of travel. So you have that person-centred health outcome. What I think this sort of demonstrates, though, is do you think that was actually being taken forward here in Tayside of delivering a lower dosage? But actually, because we've seen this being an outlier to what's going on across Scotland, the health service have faced this criticism, and certainly I think for clinicians in the oncology department, it looks like they were doing something as an outlier instead of actually trying to take forward an agenda which the Chief Medical Officer has been pushing herself on health boards. And so in terms of actually going backwards to actually set that national standard, be it for the north of Scotland or Scotland-wide, was Tayside actually doing something for the patients which now you're not going to be able to do? And I suppose my key question is what support's now being given to the oncology team in Nine Wells, given that this will be incredibly hard for them to take forward the criticism which they've faced, and also I believe the lead there resigned in November as well. So in terms of building confidence again in that team, what work's been undertaken there?
Grant Archibald.
Perhaps I could talk to that. Of all the issues I've addressed in the last 11 months, this has been one of the most challenging. We have clinicians who are highly committed to their patients, who are dedicated to doing the best thing for their patients, who are applying a judgment in that regard. We must, however, recognise that when we are doing something different, there will be challenge to that, and then it becomes about evidence, if it is there, or competing evidence. The real challenge for me is this: I need to look at the patient, and I need to understand what the patient expects. And therefore, we need to understand exactly what services we're providing in what way. I have said that where there is warranted or unwarranted variation, the challenges are different. You are right, as we go forward, the whole issue of realistic medicine will make this an even bigger area of discussion and debate. But at this time, we had a series of reports that identified that we were different and that we should look at that. And I think the encouragement we give you is we have looked at that, we have adopted the CMGs, we are taking things forward. The challenge will be, as we go forward through time, if evidence emerges for different services of treatment, then clearly that is important to understand. But I really would like to make one point, if I might, that this was a group of very highly committed, very well-intentioned, very patient-focused staff working in a whole department. And important for me, reputationally for the board, we need to recognise that there are all sorts of challenges in delivering complex care, and we are committed to doing the best that we can for patients. But where we are challenged, or where there is an identification that there is any thought that what we are doing needs to be reviewed, then we shall do it. That is our obligation, and that is what we did.
Finally, can I ask, in terms of rebuilding patient confidence, what is the board undertaking to try to rebuild public trust? And has the report and Dr. Dunlop's report been shared with all the families affected as well?
Well, David Dunlop met with a series of families and made an offer to meet others. If people do not know, he is an expert who formerly was in charge of the Beatson Oncology Centre when I worked with them in Glasgow. And actually, as he came and reviewed a series of the case notes, he thought the consenting procedures were exemplary, and he noted that in his report. The issue we've had is trying to make sure that we support those who have already had treatment and build confidence in them about their ongoing care and how we will engage with them, and importantly still, what it means for everybody else receiving care in Tayside. And our challenge in that is divided into two. The first thing is the group of patients who were affected was of the order of 304, and we have identified that if they have any issues with their care, if they have any issues with their experience going forward, any progression of their disease, which would happen in any event for some of them, but if they have the concerns in that regard, we have a list of who they are and the fact that they've been through this process, and we will engage with them in emergency clinics to support them. And we did try to offer further support by way of helplines, etc., at the time that this matter was being discussed. But if any of the families continue to be concerned, Peter and myself will look to how we re-engage further. In terms of building the confidence going forward, Nine Wells, Tayside has an excellent record in all sorts of services. So if I might give you an example, and maybe Mr. Stewart to give you an example of progressing matters. When I came back to Tayside, we were in a particularly challenged position regarding our performance in terms of cancer targets. So if colleagues know that there is a 31 and 62-day waiting time guarantee, I know this committee has discussed this with other boards. And the real issue is that in any service, but particularly in this service, the earlier the intervention, the earlier the assessment, the earlier the treatment starts, the better the prognosis for the patient. And I think that's broadly understood by the population. If we went out and spoke to people in the street, they would accept or recognise that getting early access to cancer care would be a key metaphor or a key example for them of why services are working well. And therefore we made it a commitment jointly, the three of us at this end of the table in particular, that we were going to improve that, because our current performance at that time was of the order of 85%. So we were well off the mark, we were below the Scottish average, and it was an indicator that I could not accept should be where we were. And so in a period of 6 months, we achieved a major turnaround, to the extent that at 62 days we'd improved in the last quarter to 96.9% performance against the 95% target. And in terms of 31 days, 97.6 in the period reported, I think, to September. And we have had 3 months now of us reporting above 95. Now, why is that important? Well, 2 reasons. The first thing is people are being seen quicker, and they are therefore getting their interventions, if required, more quickly. And that is seen as a key indicator to improvement of outcome. So I'm doing my job. I'm making sure patients are getting access to services. But the second thing is this, that's the first time we'd achieved that target in 4 years. In 4 years. So I think that's hugely important, not just for me, but for the clinical body to know that everybody working hard, and everybody was working hard, wasn't getting us where we needed to be. So Lorna and her team, and Peter and others sat down, deconstructed it in a granular way, looked at the queuing theory elements of the different parts of the journey, and committed to improve it. And in 6 and 7 months they have, to the extent that we're being held up as an exemplar by Scotland. And people are visiting us from Lothian, from Glasgow, from Grampian, from Fife. So it can be done, and it needs to be done. But your confidence in our cancer services, while we accept, been subject to critique, I would say, can we look at the broader concept of cancer care in Tayside per se and understand that the care we are offering now is better than it was 6 or 7 months ago, because we have reorganised things, we have made them line up better, and we are now seeing people more quickly. So I'm recognising that my 2 colleagues to my right take the great credit for that, working with their teams. But if you talk to me about cancer reputation in Tayside, I accept the issue about breast oncology and our need to discuss that, but I want to amplify the fact that in all the other cancer regimens, this improvement is real. It's not just about achievement of target, it's real for patients, and that's what we're all about.
And in 2 sentences, if you would, what's been the key to achieving that change?
I'll say 1 sentence and give Lorna one if that's okay. The key is deconstructing, understanding how things line up, getting the team to work more creatively together, rather than everybody just trying their best. Lorna?
We have a weekly huddle where we have the multidisciplinary team who all come together. We look at every single patient because it's important to us that it's an individual and it's a family going through this. And we look at their pathway, and anywhere that we've got an issue or a delay, then there'll be somebody in the room who can support that and who can move it forward. So it's actually the team all working together as one, and it works really well.
Yep. Thank you very much. I think that perhaps the single biggest issue that was raised with us by both public and health staff in our sessions yesterday evening was around mental health, and there'll be a number of questions in that area, starting with Brian Whittle.
Again, convener, I'll start with a straightforward one. I think there was widespread concerns raised about the provision of mental health services in Tayside, and well, of course, there was then announced an independent inquiry into the psychiatric unit at Carsview, and then it was widened out into other mental health services in Tayside. Can I ask then, with Dr. Strang came out with 1 recommendation out of that, why the board of the IGB have not accepted that 1 recommendation from the interim report?
Okay, so if I might set the frame, the challenge around our mental health services are very exacting at this time, and a key driver of that is the availability of consultant staff. If any service could work without 14 consultants, then you would work without 14 consultants. So that's putting a real challenge into the system. You're entirely right. This board last year, in a very look-ahead way, commissioned Dr. Strang themselves to go and look at our services and come back. And Dr. Strang did that, and as you say, he came back with one recommendation, which was that we should look at the whole system rather than look at the beds and the embedded services. If I might make 2 points about that. For us, that wasn't an either or. It wasn't that we weren't looking at the whole system. It was about the rapidity of dealing with the pressure. Myself and Peter, Gordon and others, we need to understand what the pressures are in the system. And during this year, we were working with 14 consultants down. We had 7 services that were being run entirely by locums, which is something that I would not want to do. And we had concern about our ability to manage the bed complement we had as effectively and efficiently as we can. In addition to that, the previous decision had been formed on the fact that if we went to Strathmartin at the moment, the accommodation is not what I would accept for my own relatives, so why should I expect anybody else to accept it? And there were plans to move the learning disability people out of the Strathmartin facility to Murray Royal, to far better accommodation, and centralise inpatient adult psychiatry services on the Carsview side. And I think all the intentions in that were good. As we say, Dr. Strang said that we should look at the whole system rather than just look at that part of it. My view was we were looking at the whole system. We've created what is called the Mental Health Care Alliance. Now, the Mental Health Care Alliance has the councils, ourselves, the IJBs, the police, Scottish Ambulance Service, third sector and members of the public. And it is about a root and branch review of all mental health services in Tayside. But that is going to take time. It's met 5 times already. It's looking at models and different ways of working. But that is going to take time. And the concern for Peter, myself and Gordon was, in the interim, could we afford not to do something regarding the inpatient bed decisions that had been made previously? And why would we? And therefore, that has been a challenge for us. We met David Strang as recently as last week and had a further discussion, because, can we be clear, we want to work hand in hand with Dr. Strang in his review, which we understand now will come out in January. We want to support that, but we were trying to explain to him why we felt we had these specific pressures. And these specific pressures were about the availability of senior medical staffing that are required for inpatient services. Now, in order to try to deal with that, Chair, we have brought in Mike Winter. Mike Winter is reviewing that decision or that view, and he is also reviewing all elements of the service. And he has made some creative decisions, as I say, about transferring medical budgets to nurse staffing budgets to try to ameliorate some of the risk. We also had the benefit, there was a pressing concern regarding our training provision in terms of mental health services, in the sense that NES were visiting us and we were concerned that we might lose our training accreditation because of our consultant gaps. Now, successfully, Peter and colleagues working very closely together with Mike and the team inside psychiatry have persuaded NES that we are on the front foot with this and we are trying to improve matters, and therefore the trainees have remained in place. But again, that was a pressure on us. So I think I understand why one might arrive at the view that we are unaccepting of Dr. Strang's recommendation. It really wasn't that. What we were trying to explain was we were embracing that. We were embracing a whole system view, but in the short term we thought we had a pressing need. Now, that's a debate that's ongoing, and we'll continue that debate, but in the meantime we continue to build the bigger solution, which is where are mental health services going in Tayside in the coming years, and how do we get to a more community-based model.
As I alluded to before, we took evidence last night from the public and also from clinicians, and I said I would reiterate this to yourself and allow you to respond if I could. As you've alluded to, there is a shortage of psychiatrists in the Dundee area, and the public are saying that there's that lack of, obviously leads to a lack of continuity of care, far too many locums. They feel that you're not listening and not consulting with the public, and they're not getting the access to service, and they feel they're being held at arm's length. We've then brought the healthcare professionals in, and as you have said, there's 14 vacancies currently out of 35, which is sitting at 40%, which I would say to you is much higher than in the rest of Scotland. Again, the feeling was there was a complete lack of consultation with the psychiatry unit as to the way forward. More worryingly, though, they felt they felt they had repercussions against them if they raised any issues. The word bullying was used, and also a lack of clinical lead and leadership within that. All of which, you know, if you put that together, is a very worrying picture for us to hear that kind of evidence, and especially on the back of, you know, obviously we understand that he has a very high suicide rate, has a very high issues around drug and alcohol dependency, and rates very poorly against the 18-week treatment target. And in all of that there, that to me represents a system that's in crisis. So I wonder if you could, firstly respond to that and your feeling to that, and what your plan would be to take that forward.
If I might take some of those in turn, and if I miss one, you will remind me. In terms of the design of services and the involvement of staff, I've said before we work in partnership, and this matter has been discussed at our area partnership forum, and we do have partnership arrangements inside our mental health services as well. So I'm disappointed if people feel that they're not being consulted and involved. The second thing is in terms of the clinical leadership model, we have said that we are a clinically led management enabled body, and that is working very well in acute. The challenge that we've had in psychiatry is, and this is an aggregate of many years, not a recent arrival, but we have lost clinical leaders inside that part of the service, and Peter encouraging people to step forward and become clinical leads has found colleagues less responsive to that than we have in acute services. Now, my view is architects should live in their own houses, so if people want to be part of the design, it obliges us at times to step forward. There is a reciprocity there. If people want us to listen, we really need them to step forward and stand with us to have that debate. And therefore, we need to work harder to enable the psychiatrists so to do. And again, that's why we brought Mike in, to try to build up that confidence that we're trying to do something different in this time in Tayside than previously. In terms of the public involvement and consultation, again, disappointed, because I think Tayside previously has had a good reputation in terms of its engagement with the public, and certainly through the Mental Healthcare Alliance, we have representatives of the public involved in that group. We also have third sector groups. So if that is happening, then there's maybe a dislocation about how we're communicating that, or there is a genuine issue about representation. Whichever is the case, we'll take it away, as you would expect us to from this meeting, and address it. It's not a rebuttal, it's an embracing of the criticisms that have been applied to us. We'll go and review, are we doing all that we can in that regard. In terms of the future direction of the service and how we engage that, I've said before in this meeting, and in every meeting I have with staff, and every meeting I have with the Area Partnership Forum, which I co-chair, that we are committed to working with the staff. It is not in my interest to have an environment where staff feel undervalued. Absolutely not. And you used the phrase there that I really would have hoped would not have appeared here today, which is bullying, because post-Sturrock, we have always been committed to ensuring that we work fairly with our staff wherever we can. So if there are evidences of bullying, I will say now in this public forum, people can write directly to me and I will address them, because that's not the environment we work in. That's not the way we work together. And indeed, in terms of whistleblowers or other events, I think we have 5 cases ongoing at the moment of whistleblowing about a range of subjects. We are appointing a lead for whistleblowing at the non-executive level of the board. So we take all of this very seriously. So I'm very disappointed to hear that phrase in particular, but what I'll do is I'll learn from it in the room. I'll go away, I'll speak to my staff side colleagues, and I'll speak to some of the people you've spoken to, hopefully, and find out why that is being mentioned. Because our commitment, everyone that you see on this table, everybody that works in senior management, senior clinical roles, non-executive and executive roles of the board, is absolutely committed to staff are our most valuable resource. We work with them. We support them, and we give them credit for what they do. And that is through the good times and the bad times.
Thank you for that. But you would accept then that if the staff feel that they are going to be persecuted for stepping forward, that it's very unlikely then you're going to get any collaboration with that staff.
We recently had the iMatter results back again, and the issue for me is that in the previous year that we didn't get a suitable enough response to allow us to read into the report because we were below 60%. We've only just got over it, Chair, but we're 61%, and that's allowing me to review what the staff think of the organisation. It's not really important what I think, it's what the staff think and what their lived experience is. But there should be nobody working in Tayside who thinks they can't come forward and speak to either myself or to the Chair or to anyone else in seniority. And if that is the case, then we shall pursue that, because we are a culture that embraces our staff, that works as a team, as we've just described with cancer, that seeks to empower people and seeks to make them feel rewarded for what they do. And that's been my constant narrative throughout this meeting, because that's my lived experience and that's our style.
Thank you, Commissioner. The supplementary on that, because following on from what Brian Whittle said, there was two key challenges around mental health, which was outlined to us. Firstly, people in crisis in Tayside, in all three distinct communities, really, and then beyond that, step-down facilities before people can return, hopefully, to home. And when we look across Scotland, the ability to have new facilities, to create bed space, is really important for many health boards. So when you look at the Mulberry unit at Stracathro, it just seems crazy that that's been closed to me. And I want to specifically sort of ask the board, what's your plans to reopen that? Because it's quite clear that that capacity is needed today, and it's there and could be reopened. And actually, in terms of the staffing challenge, and we've discussed that, that's key, but to look towards maybe step-down care facility to return that service to the community. And just wondered, in terms of making that happen, what the board's looking to do.
Well, again, echoing back to David Strang's report, what we're trying to do is do it all in the round, Mr Briggs, and the key issue for me is, does it make sense to make use of facilities, or does it make sense to redesign services? Because designing and having facilities without staff is no use to me. It just isn't any use to me, and I will not run unsafe staffing levels. So managing a ward is, as Ms Harper will know, a difficult issue and requires the adequate staffing to govern that. The challenge for us is this, that there has been disaffection regarding mental health services in Tayside for some time. There have been poor reports regarding suicide rates, regarding people in crisis, and not least that's why the board commissioned David Strang. I've also commissioned the Royal College of Physicians in Edinburgh, and they're going to be reporting to me before Christmas, or to the board before Christmas, regarding the governance of mental health services inside Tayside. So I've taken that move before Dr Strang's finally reported, because we see this as an area of challenge. But I need to describe to you very briefly that this is a very complex issue. If it was resolvable immediately, we would do it. So if I give you one view, the Carthew unit in Tayside, the rate of admission of Dundee residents is 50% higher than the rest of Tayside. Now, I find that an interesting figure, in the sense that I don't believe, even with some of the crises that might exist inside Dundee, that it should be so marked a variation. So that suggests to me that it's about design of services. And therefore, rather than opening more beds to deal with that, we should be doing far more with anticipatory care. What are we doing to try to anticipate those that are going into crisis? How early can we intervene, and what can we do differently? And if I might come full circle back to social prescribing, I was with the Minister down at the Botanic Gardens in Dundee about 6 months ago. And the issue there was about a form of social prescribing, which was there are lots of green spaces in Dundee, and it was a scheme to encourage people to walk, to go in organised groups and walk through parklands and park areas. And we had one person who talked very articulately, who had been in social crisis, had felt dislocated from society and was parasuicidal, and then started to talk about the fact that when he joined this walking group, not only did it give him a sense of well-being, but more importantly, it gave him a series of familial or friend connections that he didn't have. So he had access to people, and now he was training to be a park ranger. Now, I think that's a better story than giving somebody drugs or admitting them to a ward.
Fully respect that, but we're in the here and now of needing crisis beds. And so in terms of where the Mulberry unit is located, what discussions have been had with Grampian, for example, to look towards a cross-border sustainability plan to reopen that? That's kind of the question I'm wanting to see, because this is a chance to actually provide state-of-the-art facility to actually meet the need which is there today. And I completely accept we want that preventative health model, but Tayside and other parts of Scotland are in a very difficult case where people are in crisis today and needing that support.
Okay. So I understand that, but what I am looking to do is have my colleagues, such as Mike Winters and others, assess our estate and understand, just because it is there, should we provide services there, or what is the best model? And having commissioned him to come in and work with Gordon and colleagues and work with our mental health colleagues, if they arrive at that as a solution, then that's clearly the solution that we consider. But at the moment, I am awaiting a proper assessment of what can we do next and what is best that we do next. So I hear what you're saying about the Mulberry unit, and I speak to the Chief Executive of Grampian every week on a Tuesday morning, so I can have that conversation with her. But at the moment, I'm waiting to assess what can we do with the existing workforce, not necessarily just the real estate.
David Strang's report and the recommendation he made. My understanding of that recommendation was that he wanted you to stop the centralisation of services until such time as he'd been able to provide a wider recommendation. As you say, that is now due in January. You think it would have been wiser to wait for that? In other words, are you in danger of pursuing a course of closures or changes that was already underway, having been warned, wait a minute, don't do any more until you've thought about the whole picture? You say you're doing them at the same time. Is there not a risk that you will come to the end of a strategic review, conclude that you should have some of the facilities that you've actually just closed or removed, and wish that you had listened to David Strang in the first place?
I think there's but I would assure you we are listening to David and are engaging with him, as I say, as recently as last week. I think the key issue for me is about timing, and timing is rarely perfect. And we are facing a series of issues now, as colleague Mr. Whittle said, 40% vacancy rate in consultant psychiatrists. I can't say, Chair, I'm going to fill that anytime soon. We have tried internationally to fill psychiatrist jobs. We've got special dispensation from the government. We can't recruit to that. So that's my reality. That is my reality. And therefore, I am required to an extent to cut my cloth. And part of the idea about centralisation was to improve accommodation. And part of it was about a reaction to the realpolitik of where we are right now, today. It was never said that that was a once and for all arrangement. And we've had that debate with David as well. But we were seeking to have the freedom to act, even with his recommendation in place, on the basis of the pressures we had on medical staffing. And had it been that our training had been removed, our training accreditation had been removed, that would have removed 36 junior doctors from the system. So that's what we've been dealing with. And this is, I did say, a Gordian knot type problem. So I'm willing to listen to all advices, but there will be a time where Peter, myself, Gordon and others shall have to execute our role as responsible officers and either make recommendations to government or to our board that say, we hear all that, but this is where we are. But as we sit here today, we are still engaging positively with Dr. Strang. You are right, we are awaiting the report in January to see what else it says about services, but we continue to manage a system that we would not design this way were we to start again.
Thank you very much. I know Gordon Patterson wants to come in a moment. Can I just say, I think in relation to this area, one of the concerns we've heard, which I think impacts particularly on staff morale, is that some of the closures of wards, for example, at Kingsway or Craigowell, have been overnight, and that the staff involved have felt they had no advance warning of those changes, and that may well feed into demoralisation or indeed some of the key people you've talked about wishing to find jobs elsewhere. Gordon Patterson.
Thanks, Convener. I'm acutely aware of the time. I just wanted to reiterate what Grant said, because Perth and Kinross IJB host inpatient mental health services. Perth and Kinross IJB in January 2018, following extensive consultation the preceding year, which involved a range of options being considered and consultation and engagement taking place, including with the NHS Board, the 3 IJBs, the Area Partnership Forum, the Clinical Quality Forum, took the decision to approve the preferred option, which was about consolidating mental health services in Dundee, developing a centre of excellence there, consolidating learning disability services in Perth and Kinross. So that decision was taken in January 2018. Then Mr Strang obviously made his recommendation, and that was that we should pause the service redesign. We carried out a review and a risk assessment, and the IJB, Perth and Kinross IJB, determined on the 27th of September that, having taken full account of David Strang's recommendation, we should, in fact, continue with the redesign. David Strang's recommendation highlighted the need for us to develop end-to-end pathways of care, and as Grant Archibald has said, the IJB took the view that these pathways did not require to be developed while the redesign was suspended. We could proceed with the redesign. It was as much about driving forward significant environmental improvements, addressing concerns about fire safety, removing ligature anchor points, creating patient-centred environments, that we felt that to proceed on that basis would create a better environment for the small number of people who will always need hospital beds. And in doing so, that did not necessarily lock us in to that being the model moving forward, because parallel to that, extensive work is now underway with the Tayside Mental Health Alliance. It involves the 3 health and social care partnerships, NHS Tayside, Public Health, Primary Care, Staff Side, Chief Social Work Officers, advocacy groups. They're working on pathways, they're working on developing a new approach that will seek to join up the 3 strategies that the health and social care partnerships locally have developed around community mental health, which is about how we keep people well, how we respond to them in their own homes, how we marshal the resource of the third sector to ensure that they're getting alongside people and providing the necessary support. So the Mental Health Alliance is doing that work. It's looking at 5 work streams around workforce, around crisis care, sorry, Mr Briggs is gone, learning disability, rehabilitation pathways, and emotionally unstable personality disorders. So we felt that we did not need to suspend significant environmental improvements and opportunities for people to have better, safer care while we were developing a strategy. These 2 things could be done in tandem, and essentially that's where we're at now.
As the point about staff feeling that they had no notice of some of the changes that were made to their working environment.
I recognise that the staff have told you that that's a concern. I absolutely recognise that when we're doing the redesign, we have to be sensitive to the fact that if we are asking staff to transition or to be redeployed, we need to take time, we need to engage, we need to have meetings with the staff side. And actually, the progress that we've made since the IJB made the decision in January last year has been slow because we haven't wanted to rush these issues through. We've been engaging with the staff side about redeployment, about transition, about the cost and impact that that would have on staff. The 2 examples you've cited, though, I think it's important to say we felt that there had been a level of engagement, and perhaps we have to reflect on how effectively we did that. But in relation to Craigowell, we had 60 nursing shifts that could not be filled the next week. So a decision had to be taken rather urgently in order to provide safe patient care.
So on the bigger picture on mental health, I think you said you will await with interest David Strang's full report, and you said that you're carrying forward a review in parallel with the changes that have been taken forward. Who will take the lead and who will make the critical decisions on mental health strategy post the receipt of David Strang's full report? Where will that responsibility lie?
Well, I think that's a joint responsibility because we will have to work in tandem. So while there are hosted services, as I've said, Peter and I, myself as the accountable officer, Peter is the senior medical officer of NHS Tayside, our responsibility is to the patients. That is not a confused landscape for me. That is an issue of myself working collaboratively and collegiately with my IJB, which was the whole intention of hosting arrangements. and the responsibility for patients never leaves myself or Peter, and the issue of hosting and design of services is a key area that has been delegated to the IJB. If we are at a different place, that should be incredibly disappointing because we work so closely together.
Move on now to primary care and David Stewart.
Thank you, Convener. How well does the new GP contract work in Tayside?
I think I'll ask Peter to answer that one better than I.
The new GP contract is a primary care contract. It's about reorganising primary care around a more integrated approach with other workers. So in respect to moving forward on that, it's slow progress. I've got asked for an interim report on this. The issues are obviously also include premises, so we are taking over and building places in Errol. We've obviously had issues with the Bridge of Erne practice and its accommodation. It's also in terms of IT provision, so there are a number of initiatives there that are going forward and have timetables attached to them, but most of the IT provision is relatively old, so that needs to be replaced.
And you've touched on some of my further questions, but I'm particularly interested about rural areas. The committee has taken a lot of evidence from various organisations about rural provision. As you know, the Royal College of GPs had some question marks about the contract, particularly around rural provision. And you've touched on Bridge of Erne. I understand that 3,000 patients had to be redistributed, inverted commas, to various practices, including in Perth. I mean, that's major disruption. I mean, how well does the contract serve rural GPs?
In terms of going forward, well, Bridge of Erne was a private provider, independent provider, general practice. We currently have a mixed economy in terms of having 2C practices, which Health Board run. We have 4 of those, and the other, I think it's 59, are partnered practices. So in terms of how the two work together, we coordinate those through our primary care medical services and our associate medical director in primary care, which is Jane Bruce. That seems to have gone, despite the issues, relatively well in terms of safeguarding patient safety and patient access to primary care services. There is some further planning needed in terms of going forward in the provision of care in Perth and Kinross in particular. We do have standing operating procedures being developed in terms of similar events. We have had similar experience in Dundee, but that was somewhat easier to deal with because we already had 2C practice existing and there was a significant amount of cross cover. Rural recruitment is very difficult, and there are clearly at least one practice that is vulnerable to that, but the combination of the good relationships between the Health Board practices and the surrounding partner practices in that circumstances are providing cover.
Through you, Convener, do you have a list of GP practices that you consider highly at risk? Because clearly this is about prevention and damage limitation in the long term. We've already heard that 3,000 patients had to be redistributed. I mean, roughly in numbers terms, how many GP practices are at risk of closing down within the Tayside Health Board area?
Perhaps I could comment on that and just take us back. The Bridge of Erne practice had a series of almost unique complexities around it that led to a difficult decision and a reasonably late decision for which we've apologised, which saw the patients distributed rather than some other model adopted. And the reason for that is that was considered to be the best interest of the patients. It did cause inconvenience, but there were issues about the unwillingness or unavailability for other people to take over that practice and the fact that for many years it had found difficulty in recruiting GPs to it. We have committed to work with Gordon and colleagues regarding the ongoing provision of key care services in the Bridge of Erne environment. So those are nursing services particularly, and we are redeveloping a property that we own, the board owns, inside the village at the moment, and that is an ongoing piece of work. In addition to that, we met with Karen Reid from the council and with Gordon to discuss the change in the demography and morbidity of Perth, both planned and unplanned. I understand there are 7,500 new houses to be built in Perth area in the next few years, And therefore, that materially changes the profile of certain areas. And we have agreed that we will be involved as one of the key services. In addition to schools, GP practices will be part of that debate. So we're doing all of that. We're also doing a review of the events that compressed into the Bridge of Erne practice so that we learn from that experience. Off the back of that, and coming to your question, off the back of that, I immediately asked Jane Bruce from our primary care division to start to review now those practices elsewhere across the rurality, particularly, of Tayside that might be vulnerable. And those that might be vulnerable are single-handed practices where an elderly GP seeks to retire, or it might indeed be an issue of the property they're in and its inability to provide a range of services going forward. And so to that extent, we've also called on the support of Sir Lewis Ritchie. And Sir Lewis and I have agreed a series of terms of reference which he is going to engage with me and give us advice on hubs. He's going to visit Bridge of Erne. He's going to visit other rural parts of Tayside. And our challenge in that is we may need to look at GP practices coming together or satellite services, but what we need to do is reinvigorate those. And part of the debate we're having with Karen Reid is about the co-location of services. So what might be put on the Perth Royal site that creates a hub around social work, etc., as well as around GP services, etc. What can we do in Pitlochry? What can we do in Auchterarder? So we have a list. I don't have the list or the number exactly at hand at the moment, but we've already commissioned that review, and it's a RAG rating, a red, amber, green rating of the most at-risk practices, because what we do not want to do is find ourselves in a series of circumstances, albeit that they were unique, in Bridge of Erne. And we have apologised to the populace for that, and our commitment is we are looking again at what services can be provided there pro tem, and then have a bigger debate as that population changes. I think there's 750 houses might be being built around Bridge of Erne. Then if that were to be the case, we would have to look at a different setup. And that's where Sir Lewis Ritchie's ideas will help us.
Well, thank you for that. I wasn't really expecting you to have the figures necessarily to hand, but would you be able to write to the committee with the number of GP practices at risk within Tayside and the number of patients who are potentially involved? That's very useful for the committee to know long term. Could I also touch on another point that the medical director raised, and that's the issue of boards taking over GP premises. Obviously, I've discussed it within my own board in Highland. I've met many GPs about this. Now, there's pros and cons about this. This can be a positive development, but my first question touched on finance, and clearly that would be an issue I would want to raise very directly with you. If you are, in the long term, taking over the premises of every GP practice within Tayside, that's an immense financial undertaking. Have you had any assurances from government that there will be direct government support for your ability to buy new GP premises or take over existing GP premises within whatever timescale? But it's certainly a commitment within the contract, is it not?
That remains a work in progress at this time, as you would understand. But one of the things that we're doing, and I've commissioned, we were doing a site review in any event of all the properties. I did say at the start that we're the third biggest property owner of all the boards in Scotland. And we need to challenge that because we have quite a large backlog maintenance challenge. And the issue is, why put money into properties if we could get out of them? And the other thing is, where is the potential for joint property relationships with the council? If we take Brechin High School, Brechin High School was built with a deliberate extra wing on it that allows drop-in centres for men's clubs, etc. So it's putting it at the heart of the community, and it's that sort of flexibility we need. So we're assessing all our properties. You're right, added to that is the schedule of the GP practices, and there is a spectrum of those, to my knowledge, from those that would need quite a bit of refurbishment to those that have been relatively newly built or maintained. We would need to design what the models are and then think about what the properties are. So form would follow function. I'm not a greater believer in building something and then using it. Let us design the model and see what can be built around it. And again, I know I'm calling very heavily on Sir Lewis in this regard, but he had such invigorating ideas about creative hubs that supported communities and played a bigger role than just being a GP practice, that we are keen to engage with his ideas and examples from elsewhere.
Clearly in Tayside and the rest of Scotland, many GP practices will require either accommodations with other GPs, but particularly new premises to allow allied health professionals to carry out the excellent work that they carry out currently, perhaps not on site. Yeah. But on the financial front, I know you don't have categoric answers at present from government, but it would seem to me this is a huge financial commitment. I don't know if Stuart Lyle's in a position to answer this, but is this something you would have on a risk register? Because if you were taking over commitments to provide premises for GPs across this really large region, that's a massive financial commitment. Is there not huge red flags about this? Financial responsibility to a region that's had, what, 80 million plus in brokerage?
Stuart, do you want to?
Yeah,
Sorry, throwing you a difficult question, the very last one, but this is a crucial issue, I think.
It is a crucial issue. I mean, we have a primary care premises group set up locally to look at this issue. In terms of costs that the board may inherit, we're modelling those and we're comparing that with funding that may or may not be available. I can't answer categorically whether the funding would cover the cost at this moment in time. I don't have that information available.
Do you have a financial risk register as part of your operation as Director of Finance? And
yes.
Is that a potential issue? Is that on a risk register?
Yes. Yes.
Is it high up the risk register?
It's high up the risk register, but our overall property per se is high up on our risk register because we've got a number of properties that we need to look at. And we've got high backlog maintenance. We've got too many properties, to be blunt. So there's a whole kind of infrastructure around addressing the property framework that we have.
And I won't open another line because I know we're tight for time, Commissioner, but clearly you know the work we've done in Queen Elizabeth about water bacterial infection. So clearly having a very large site also has issues about hygiene and infection, about risk that vulnerable patients could be at. Well, thank you for that. It's useful to know that this is high up the risk register. It's certainly something we're raised with other boards, but I think it's a good idea about providing GP premises, but I am concerned about how this is going to be financed in boards that already have had quite severe financial worries over the last few years.
Thank you very much. A supplementary from Emma Harper.
Yep, it's. I think we should be doing some good news stories as well. The Scottish Graduate Entry to Medical School is a programme that NHS Tayside are participating in. So that's a way that we can get rural GPs and people growing our own graduates into medical practice. But I'm also interested in the better health and better care aspects of our briefing are in page 237 and 239 of the 326 pages. It talks about the good news that's out there, the work that's been done, and all the staff should be commended for taking the better care and better health programmes forward. And earlier, Grant Archibald, you said that you would be willing to learn from other boards, but I'm sure they can learn from you as well when we look at alcohol, brief interventions, child healthy weights, dental stuff, smoking cessation. There's other issues of addressing deteriorating patients in acute care as well as the community. So it would be good to maybe hear some of the good news stories as well.
Well, we started off, thank you for the question, and we started off genuinely by saying we are the product of our staff. We are a staff-based service, and it is the individual efforts of 14,000 people and all those that work in social work, etc., that work in partnership with us that dictate whether we're successful or not. And that's why I was keen to understand from Mr. Whittle any concerns that there are among the staff. Because our commitment is we work as a team, we work best as a team. I am immensely proud of so many things in Tayside. This week, Lorna will be embarrassed to report, but we achieved 98% for the unscheduled care performance. I think that's the first time a major board's achieved that in Scotland for some considerable time. And I think I heard the Minister say before that we were 10 or 15 points better than England. So we are doing things well there. The cancer services we've already talked about, the development of our relationship with the medical and nursing schools in Dundee are exemplary. We have regular engagements with them because part of our plea is if you work in Dundee or you've trained in Dundee, how do we get you to stay working for Tayside? And that's about making us an attractive proposition. We were recently at the Daily Record Staff Awards where our liver treatment unit and analysis won another national award. I think they're running out of shelf space for all the awards they won for that. And there is something about celebrating success. When something goes wrong in the health service, it is so important. It's a tragedy for an individual family or for other people. So we must understand that we're in a business, we're in a service delivery model that has to recognise the huge implications when things don't go right. And therefore it's right that we concentrate on those when they happen and that we we learn from them. But by the same token, every day in all our hospitals, in all our services, in our GP practices and beyond, people are working incredibly hard and delivering excellent services. And I think in some of the key areas that you've alluded to already, we are doing very well indeed, and we need to build further on those. And I'm particularly impressed by the efforts that we are making about child health and healthy weights, and also our efforts around cessation of smoking. A lot of what we've talked about today, for me, resides in an environment about public health. We want to become a health service, not an ill health service in Tayside. We want to promote health in every way we want. We want to anticipate when people are getting into psychological despair or disorder and support them, or those that are finding their way into drug use, and have anticipatory care models for that in the same way as we do for COPD. We need to get out there and play our role. We're the biggest employer in Tayside. There can't be many people in Tayside who don't have a relative who want to work for the health service. My aim, the chair in mind, is for those staff to feel proud of what they do, feel rewarded and recognised for what they do, and see the product of their efforts and that they're listened to.
Excellent. Can I say to all our witnesses, thank you very much for your evidence this morning, and to all those who attended and supported our private sessions as well. We're very grateful, as well as to those who've come to hear this session today. As indicated earlier on, there will be some questions where you've offered and others where we may ask for some additional information, and we'll be in touch with NHS Tayside and the IJBs accordingly very shortly. So thank you all very much, and I now close this meeting.